Okay, we will go ahead and get started. So first, to start off, I want to thank all of you for being here and your interest in coming to learn about this topic and hearing what we found out and hearing what we have to say about it. So if you by chance don't know me or who I am, my name is Dr. Lindsey McCormick. I'm an assistant professor here at the Chicago School in the Counselor Education Department online. I'm a certified perinatal mental health specialist, certified lactation counselor, and an EMDR certified therapist and approved consultant. And I am joined by my co-presenter today, who I will let introduce herself.
Hi everyone, I'm Hannah. I'm a third year grad student in the CMHC program, and I've been assisting Dr. McCormick on this piece of research we've been doing since about last fall, I want to say, and it's been
Mhm.
a really important experience for me and kind of processing my own traumatic birth. So I'm very excited to be a part of this.
Yeah, thank you. So we have quite a bit that is in this presentation that I hope we don't speed through. But I want to ensure or make sure that we have time and opportunity to talk about all the sort of pieces and components that went into putting this work together, in addition to doing the actual work and going through the results. So these are some of the things that, generally speaking, we're going to talk about with regards to learning objectives. And I do include the content warning of the fact that this is a presentation on the lived experience of folks who've had traumatic birthing experiences. That includes myself and Hannah. And so there will be a little bit of information with regards to those lived experiences and things of that nature that are discussed in this. So in the interest of being trauma informed, I would encourage you to do whatever you need to do to take care of yourself if any of those things feel activating for you at all.
Okie dokie. I'm going to start us out with an overview on PTSD in the postpartum period, and then I will let Dr. McCormick take over from there. But most of y'all are familiar with PTSD and its symptomology. It's a mental health condition that can develop after experiencing or witnessing a traumatic event, including a birth. Symptoms of PTSD typically fall into four categories: flashbacks, nightmares, alterations in cognitions and mood. Oh, I said that wrong. Intrusion, avoidance, negative alterations in cognition and mood, and alterations in arousal and reactivity. Intrusion symptoms, there we go, include intrusive memories, flashbacks, nightmares, emotional distress, or physiological reactions when exposed to reminders of the traumatic event. Avoidance symptoms involve efforts to avoid thoughts, feelings, or reminders of the traumatic event, as well as avoiding activities, places, or people associated with the trauma. Negative alterations in cognition and mood may manifest as a persistent negative belief or expectations, distorted blame of oneself or others, persistent negative emotions, and feelings of detachment or estrangement from others, which can be particularly difficult in the postpartum period. Alterations in arousal and activity can include hypervigilance, exaggerated startle response, difficulty concentrating, sleep disturbances, and irritability or anger outbursts. So, the way that this impacts the way PTSD symptoms impact the postpartum period, the first off, the postpartum period encompasses the first few weeks to months after childbirth, which can be particularly challenging when dealing with PTSD. It's very emotionally charged time, lots of hormonal changes. These hormonal changes and sleep deprivation, stress associated with caring for a newborn can exacerbate these PTSD symptoms and make coping more difficult. The intrusive memories and flashbacks and nightmares of the traumatic childbirth can interfere with bonding with the baby and lead to heightened anxiety and distress. Um, Avoidance of medical settings or reminders of the traumatic event may prevent individuals from seeking necessary postpartum care, like their 6-week postpartum checkup when you go back to your provider and get all of your stitches and whatnot checked. That can be a very triggering experience. Also going to the pediatrician appointments, checking up on the baby's health, that can be very triggering, which exacerbates physical and mental health issues. Negative alterations in mood and cognition may impact self-esteem, parenting confidence, and the ability to engage in enjoyable activities or seek support. There's this idea that it takes a village to raise a baby, but when you're dealing with PTSD after a traumatic birth, utilizing that village, if you happen to have one, can be so challenging. It's not as easy as accepting help, especially after a birth trauma. Alterations in arousal and reactivity, such as hypervigilance and irritability, can strain relationships with partners, family members, and healthcare providers, further isolating individuals with PTSD. So, like I said, utilizing that village in those early days and struggling with PTSD isn't as straightforward as we might think. But that concludes the overview on PTSD, and I will hand it back to Dr. Brown, Dr. McCormick.
So, as Hannah mentioned, PTSD and experiencing PTSD after a traumatic birthing experience can have an impact on how that birthing person bonds with that infant. And so when we think about infancy, or when infancy is defined, most folks tend to define infancy as 0 to 12 months. But in reality, from a neurodevelopment standpoint, when we think about and talk about infancy with neurodevelopment, we're talking about birth to 3 years. Many of the programs and things that exist within our various states with regards to development and things of that nature, if you pay attention, they're titled things like birth to 3 or 0 to 3 or things of that nature to, again, place emphasis on the fact there's a lot of things that happen from that 0 to 3 infancy window with regards to neurodevelopment. This is also the time where we formulate attachment and our sort of like attachment style, our initial attachment style is developed. And so you've got insecure attachment versus all of the secure attachment versus the subtypes of the insecure attachment. So, you know, your disorganized attachment and things of that nature. And so body feeding actually plays a role in attachment for a lot of reasons that will be talked about and addressed in a couple of slides here in the future. But body feeding tends to play a role in attachment because of what is happening with regards to the neurological piece, because of the different hormones that are released during the engaging in that body feeding relationship. So you've got this experience that can have not only a profound and a significant impact on how that person's that has a profound impact on that person's sense of safety, sense of well-being, sense of self, to make the experience traumatic. But you also have the addition of the mental health symptoms that can develop because of the experience, that can lead folks to feeling detached from their own selves, can lead folks to maybe not wanting to engage in or keep their infant at a distance because of this feeling, because of the different symptomology they might be experiencing from PTSD and so on. But there are a lot of impacts that that untreated perinatal mental health conditions, like PTSD that's developed in the perinatal experience, can have a trickle down effect on the infant or the child, the other children, if there are other children in that family. It has an impact on the entire family unit. And so when we look at traumatic stress, and traumatic stress in terms of neurodevelopment and how kiddos, infants and toddlers, have traumatic experiences, there is a lot of work that has been done, especially in the EMDR community, around developmental, or sometimes called pre-verbal trauma. And so that pre-trauma, or that pre-verbal trauma period that we look at, is 0 to 3 years. And oftentimes when folks work with those individuals can't recall specific memories that are tied to maybe being born in a very traumatic way or experiencing birth in a very traumatic way. But it is oftentimes those folks are having somatic experiences that are tied to that traumatic experience. So somatic experiencing, somatic processing, goes back to that sort of idea of Besser van der Kolk's the body keeps the score, in that with regards to, you don't necessarily have to have an explicit memory to be able to pull out of your brain or be able to identify that is a traumatic experience, but that if you've had a traumatic experience that is stored in your implicit memory, that is more of a right brain, what would be termed as a right brain experience, then folks will likely experience that on a somatic level, through headaches, fatigue, nausea, or isolated like pain points within the body. And so I also have, listed on here polyvagal theory. And part of the reason why I put polyvagal theory on this slide was just to also sort of talk about and identify that, like, when we think about polyvagal theory, being able to attune to oneself, so co-regulation, but regulate themselves, they have to have someone that is regulated to be able to engage in co-regulation with them. If you have a parent that is experiencing symptoms of PTSD, their attunement and their ability to co-regulate is not going to be very strong. And one of the ways that we build what's known as vagal tone in polyvagal theory, one of the ways that we build vagal tone is through co-regulation. And so our being able to co-regulate with that infant helps build the vagal tone, just like if you're toning other muscles or engaging in other muscular work to tone muscles. The vagus nerve is the same way. So skin to skin care. As I went through my lactation counselor training, I really came to learn a lot about skin to skin care and the benefits of skin to skin care. So sometimes this is referred to as kangaroo care. But the idea, if you're not familiar with the concept of skin to skin care, is that essentially you've got a birthing person's bare chest, and that infant gets placed on that birthing person's bare chest, and the neurological benefits for both that birthing person and that infant are like they're phenomenal. Initially, when kangaroo care started to become a thing in the hospital setting, it was introduced in the NICU units, oftentimes because they saw the neurological benefit, the way that physically those neonates improved with regards to their breathing, with regards to thermoregulation, with regards to their brain activity. It became very widely used in NICUs, and then has since then been used in much more mainstream with regards to birth work. And so you have things like the Baby Friendly Hospital Initiative, where skin-to-skin care and evidence-based skin-to-skin care is defined as within that first hour after birth, that entire hour that infant is laid on that birthing person's chest. Anything with regards to AVSCAR or APSCAR scores, or any of the other sort of like checking and things of that nature that they do once someone's caught that infant, or that infant has been given birth. All of those things can be done while the infant is on that parent's chest. But it's that first feed, if that person is engaging in body feeding, then the first feed is supposed to occur within 1 hour post-birth. And again, that is skin to skin care, that is evidence-based with regards to and looking at the Baby Friendly Hospital Initiative, which has been a program to help these hospital settings get more on board with and engaging in things like rooming in and things like lactation care and so on and so forth. But like I said, the neurological benefits of skin to skin care and being in that close body contact are vast. And so there's a lot of different hormonal changes and shifts that not only happen in the postpartum period, or even within those first few hours post-birth, when the estrogen rates significantly decrease. I mean, just bottom out. Prolactin significantly increases to allow for human milk to be produced. But when you have when you have the infant on that mother's chest or that birthing person's chest, what happens with regards to hormones from a neurologic standpoint is you have the release of oxytocin in the dyad. So both of them are engaging in that oxytocin release. Oxytocin is the love hormone. So it helps to start to foster that attachment, even in just that initial, even in just those first few moments. And so one of the reasons why I really wanted to look into doing some of this specialized work is because in 2021, I gave birth to my first child, my only child at this time. And what was seemingly a routine induction at 41 weeks to the day was a seemingly routine and normal induction in the first 12 hours. And then the 12 hours after that was not. And so there were a lot of factors, intervention, distress, intervention, fetal distress, intervention, parental distress. So all of these things continued to stack up. And ultimately, I ended up having an emergency C-section. And my life and my infant's life was at risk in that time. And one of the things that I found postpartum in my postpartum experience that was really helpful for me in processing this lived experience and having this negative response to induction was engaging in skin-to-skin care frequently and often with my newborn. And even in that, after that quote unquote fourth trimester phase, so those 12 weeks postpartum, we continued to engage in skin-to-skin care from time to time. And there were a lot of really healing benefits to that. And I feel like, given the bond and the relationship that I have with my kiddo now, that time and that experience was definitely it was relational. There were benefits that we both received in that from having this shared lived traumatic experience from two different perspectives too. Hannah?
Yeah, so similarly, this being involved in this was born out of personal experience. I've given birth twice, and they were both similar setups, both inductions, epidurals, vaginal deliveries. Both boys needed to be monitored for low blood sugar shortly after birth. But with my second birth, I was induced due to gestational hypertension, which I did not know at the time, but it comes with an increased risk of postpartum hemorrhage, which did a couple hours after giving birth to my second son, I hemorrhaged. And the intervention for a hemorrhage is incredibly invasive, incredibly painful. The epidural had worn off. And then while that was happening, my son was taken to the NICU because his blood sugars weren't recovering like we hoped. So we really only got maybe the first hour for skin to skin before we both started just declining rapidly. And then while I recovered from my hemorrhage and getting blood transfusions, I wasn't able to go down to the NICU to visit him for his first day of life. So a lot of effort afterwards was put into place in giving us the opportunity for skin to skin care, but that first maybe 12 hours was really missed out on, and that was a really difficult experience for both of us. And he ended up struggling with low birth weight and failure to thrive for quite some time, so that may have played a part in that. But yeah.
Thank you.
Mhm.
And the thing about doing qualitative research and doing a qualitative research project like this one is that for a lot of folks who engage in and do qualitative work, it comes from passion from the researchers, whether that passion be their own lived experience or something else, trying to take our own selves out of qualitative work can be difficult, simply because we have so much passion, motivation, and drive to want to seek questions and or seek answers to questions, excuse me, seek answers to the questions that we have. And I feel like try to work towards doing some meaning making out of these shared experiences, out of lived experience, and coming to terms with those experiences. So with all of that, we looked at these different hypotheses. I put these hypotheses together. These were things that I wanted to look at, ask, learn more about with regards to all of this information that I had learned, because my lived experience, not only did I have my lived experience, and then I was working in trauma and traumatic stress already. I've worked in traumatic stress for a long time, but then it changed the entire trajectory of my career with regards to specializing in perinatal mental health. So there were a lot of things that I learned about that, in addition to the things that I learned in my lactation care training, and a lot of the public health, sort of the people that I've met through the work that I've been able to do in the last couple of years, that really, like I said, it got me to the point that I did with these particular hypotheses and looking at these lived experiences. So the criteria, we did some interviews with folks who had given birth in the last 12 months, that birthing experience was considered traumatic to them. They had engaged in skin to skin care at any point in that 12 weeks post birth, that they had engaged in some type of body feeding at any point, and that they had, if they had struggled with any sort of mental health problems after they had that traumatic birthing experience. I recruited, excuse me, using a couple of Facebook groups that I'm in, as well as the Postpartum Support International listserv for participants, and selected folks completely at random, and had 7 participants total, but ended up having to omit, excuse me, one of the interviews due to connectivity issues. And so the interview ended up not being a complete interview. So interviews were done via Zoom, recorded via Zoom, and were semi-structured. I used in vivo to go through the analysis process. And when I was going through and analyzing transcripts, one of the analysis approach that I was using was transcendental phenomenology, because I feel that with transcendental phenomenology, because part of the purpose or the goal is to have meaning or to derive meaning from lived experience, that felt like the best way or the most appropriate way to go through and analyze transcripts based on what I was looking for. So this word cloud were just some of the very common words that came up throughout each transcript with each participant, as well as these being the synonyms of some of those words that were the most used words within that transcript analysis. And so what you're looking at here is how much each one of the transcripts from each participant was related. And so where some of those themes, which I'm going to talk about some of those specific themes here shortly, where some of those themes were that overlapped. So within the recurring themes and codes, the biggest one, or one of the biggest ones that I pulled through, was sentiment. And when we're talking about traumatic birth and traumatic birthing experiences and asking folks about their lived experiences with a traumatic birth, it came as no surprise to me that the sentiment that folks talked about their lived experience with was generally negative. The positive pieces or the positive sentiment that did come through, for the most part, was more so related to the things that they felt like helped them with regards to helping them with their mental health, helping them with their body feeding goals, or things of that nature. So I pulled a couple of quotes here from a couple of the transcripts, just to give you sort of an idea of what the negative sentiment sort of looks like, or what some of those things were that folks were talking about that were negative. Experiencing guilt because of having panic attacks from living through this traumatic experience, struggling with lactation and feeling completely helpless, feeling like they were failing with regards to not being able to engage in body feeding in the way that they thought they should be. And here are a couple more with regards to negative sentiment. Again, one individual talking about not knowing for a couple hours postpartum how their infant was doing, being separated, being stressful. And one individual talking about their lived experience and not engaging in skin to skin care, and a lot of the negativity that they felt with not only the birthing experience, but some of the shame that they felt in the emotions that they had towards their infant. Speaking to guilt, another big recurring theme was folks experiencing guilt. And the guilt could have been from a lot of different things. There were a lot of different reasons behind said guilt. Whether that be because they did not engage in skin-to-skin care the way they wanted to, or the way they knew that they should, so to speak, because they maybe didn't meet their lactation goals, and maybe didn't have as much support as they thought they would or had wanted to, didn't know how to get that support. So feeling the guilt of that, feeling guilt with regards to experiencing anxiety, experiencing a decrease in their overall mental health, and knowing that it was, or maybe not necessarily knowing, but more so having the sense of, or this underlying feeling that the infant was being negatively impacted by their decrease in mental health, which we know from things like the ACEs study and whatnot, that can be true. But there were a lot of times where folks expressed that sentiment of guilt, which, from thinking about it from a traumatic stress standpoint, certainly makes sense, because when we experience trauma and traumatic stress, oftentimes when we're experiencing those symptoms that are related to PTSD, and we're struggling to make sense of that traumatic experience, folks get stuck, so to speak, or surrounding things about guilt, about shame, responsibility, and who might be to blame for what had happened. Then another big theme is that their mental health was negatively impacted. Folks talked about experiencing depression, that they had struggled with just being able to not being able to move past or move forward after having this lived experience, and how their decline in mental health after this experience also started to bleed over into other aspects of their life, including how they might have been parenting their other children in the home, or not socializing, or engaging in their friendships, outside relationships, things of that nature. So, as the title of the presentation implies, clinical implications. How do we take this this research? How do we take these lived experiences as clinicians and use that as a way to learn and engage in our own clinical practice? One of the biggest things that I took away from all of this is that every single participant had identified their experience as traumatic, but not only was the experience traumatic for them, it was traumatic for 6 different reasons. 6 different participants, 6 completely different reasons. And the reasons varied so vastly that it was a great reminder and serves as a great reminder that trauma is subjective. So it doesn't matter what we think is traumatic. If that lived experience is traumatic to that individual, then it's traumatic to that individual. And it's not up to us as clinicians to try to help them see otherwise. I also, I think there continues to be this idea of big T trauma, little t trauma. And I think this is a good sort of reminder that big T trauma and little t trauma don't actually exist. That trauma is trauma is trauma. It doesn't matter what degree or magnitude of the experience, what the degree or magnitude of the experience is. If it's traumatic for that person, it's traumatic for that person. And your nervous system doesn't know the difference in a big T trauma or a little t trauma. All it knows is trauma response. And when it experiences a threat to safety, a threat to self, it's going to engage in a sympathetic nervous system response. So I say again, traumatic experiences are subjective. Every client that we work with is going to have a different type of lived experience that's going to be traumatic for them. Traumatic birthing experiences also have that significant impact on the postpartum experience, which was confirmed in this research, and also confirmed, we have the literature that shows some of that as well, and that it can have an impact on the way that folks engage in bonding and engage in care. There's also, I mentioned a couple slides ago talking about guilt, shame, responsibility. It also gives resonance to what's sort of deemed as the mother myth, which is this idea that if I was a good enough parent, things like bad things wouldn't happen, or a good parent knows how to do. A good parent knows how to do X, Y, or Z, or a better parent would know how to do X, Y, or Z, which can feed into that guilt and shame spiral, as well as decreases self-efficacy with regards to parenting, which, if you have that decrease in self-efficacy to parenting, you're also going to have a decrease in an ability to co-regulate, which goes back again to the ability to foster attachment, the ability to formulate attachment, and having the mental health aspects of that lack of co-regulation, being able to provide that secure attachment, or that secure base for that infant or toddler. And that we don't really do enough screening. And this is not just in perinatal mental health. This is not just in mental health in general. This goes across the board with regards to healthcare providers. We don't do enough screening for traumatic stress. And so one of the things that we need to continue to do and make sure that we are engaging in is screening. Screening for traumatic stress is very important, because it can have so many bleed overs into other aspects of folks' lives. And lastly, there's still a lot of limited visibility for folks who work with and specialize in perinatal mood and anxiety disorders. And truly, I even for myself, before I started specializing in this area, I didn't even know it was an area that folks specialized in for a while. But I think that too goes back to that perception of like my own lived experience and the motivation to make an impact in this field and bring some visibility and awareness to the impact of perinatal mental health, parental identity development, attachment formulation, and all of those things that in clinical practice, in my own clinical practice, I was doing a little bit already, but wasn't doing to the magnitude that I have been. So in regards to future research, we'll wrap up and do a couple questions if anybody's got any. One of the things that I really want to continue to work on is incorporating incorporating skin to skin care into therapeutic practice, and figuring out a way to engage in incorporating skin to skin care in the therapeutic space that is trauma informed, that is ethical, that is beneficial, maybe through the lens of an advanced protocol or a modification to standard protocol for EMDR therapy. I have had folks that I've worked with in the last couple of years use skin to skin care as a resource skill that I've been working with, and like just engaging in skin to skin care and adding bilateral stimulation during that time. And it being very beneficial for those folks. So that is something that, like I said, I want to continue to work on and think about, that I've continued to conceptualize since my own lived experience, and how beneficial skin to skin care was for me, how beneficial the research continues to say that it is for that parent infant dyad, and so on. Any questions folks have? You can come off mute if you would like to, or you can put them in the chat if you would like to. So there is a question in the chat with regards to engaging in skin to skin, and if skin to skin care could be beneficial with older children that are struggling with attachment issues. I would say, or I feel like there are other ways that we go about doing that when kiddos get to be a certain age. Often, even if folks are engaging in what is termed or deemed long-term body feeding. So engaging in body feeding when kiddos are 3 and 4 years old. There is still some skin to skin that happens in that, or can happen within that. But at that point, I would my best guess or my clinical opinion would be that there would be other methods that we could use to help with attachment that aren't necessarily towards or leaning towards skin to skin care. Parent-child interaction therapy, child-parent psychotherapy, which tends to be from that 0 to 6 age range, as well, engaging in attachment focused EMDR therapy. But there's a lot of therapeutic interventions, therapeutic modalities that we have that can help with attachment when kiddos get to be a certain advanced, or maybe not advanced, but like a certain age level. Any other questions? Okay. Well, if there are no other questions, I want to thank you all again for being here. If you have any questions, I've put mine and Hannah's contact information here. That QR is my digital business card as well. But thank you all so much again. I really appreciate you all being here.